Hello everyone, I'm Dr. Kevin, a dentist based in Sydney with experience in both public and private practice, as well as university teaching. Now, a group of us are putting some resources together on this platform to hopefully encourage a multidisciplinary approach towards the provision of healthcare and hope you enjoy these discussions. So the first topic we're going to discuss is odontogenic pain presentations. It's often the reason why our patients present to our clinic in the first place. While this won't be a detailed presentation on endodontic diagnosis in a dental setting, we will aim to discuss some common presentations of odontogenic pain and hopefully give us a better understanding of the questions we need to ask when taking a pain history. It is important to recognize that there are many causes of odontogenic pain and presentations may vary, and there are also conditions that may mimic odontogenic pain. There are also times where patients are unable to locate a specific tooth and can only point to the area of concern. So given the complexity of the topic, it's important to develop a systematic approach towards diagnosis and management of odontogenic pain. And hopefully through these presentations, we can provide an outline for the diagnostic process, as well as describing a few typical presentations that we may encounter. So the main topics we will be discussing first are the process of taking a comprehensive history and performing an examination in the context of a toothache patient. And then we'll be going over some common presentations and management strategies in a medical setting in the following video. To start off with, here's a simplified list of potential sources of orofacial pain. Number one on the list is periodontal, so anything that affects tissues around the teeth. It could be acute, it could be chronic. Sometimes it can be pericoronitis, where there's soft tissue inflammation around the impacted wisdom teeth, in which case good oral hygiene chlorhexidine mouthwash for a short period of time can help, and referrals to be made for dental management. Number two on the list of orofacial pain is dental. So it could be dentinal hypersensitivity from exposed dentine being stimulated by cold, sweet, or acidic stimulus. It can be from occlusal trauma, such as clenching and grinding, cracked teeth, or caries. It can also be pulpal, so reversible or irreversible pulpitis. In the case of reversible pulpitis, the patient may experience sharp, non-lingering sensitivity to mild cold stimulus, and it can be caused by things such as caries, trauma, physical, chemical, and thermal causes of pulpal inflammation, where the pulp recovers with time after the appropriate treatment has been completed. In the case of irreversible pulpitis, there's a sharp, non-lingering or lingering sensitivity to mild hot and cold stimulus that does not resolve with time. And then part of dental, we can also have periapical, so apical periodontitis, inflammation of the tissues apical to the tooth. There's also non-odontogenic causes of orofacial pain, such as musculoskeletal (TMJ) issues, sinus problems, cardiac, mucosal, salivary gland, lymphatic, or dry socket after a dental extraction. So here's a list of pulpal differential diagnosis and periapical differential diagnosis. While we won't be going through these diagnoses in detail, it is important to recognize that there is a pulpal and periapical component to a diagnosis, and these can correlate to some of the different symptoms experienced by our patients. So let's go into the pre-examination interview and see what questions we need to ask as part of the pre-examination interview. So we ask questions regarding dental history and social history, such as, in general, has there been a history of tooth loss due to caries, due to periodontal disease in the past? Is there anything specific to the area, such as extractions or root canal treatment or fillings done recently in that area? Has there been any history of trauma, such as clenching and grinding? And also, we need to ask about the history of the symptoms. The first question to ask is location. Where is the pain? So, can you localize it? Or we need to consider also referred pain. We need to confirm the location clinically. Then we ask about onset. When did it start? Was there a specific incident, such as trauma, biting, or recently any dental treatment done in the area? Then we ask about timing. So how often does a pain occur? Is it a constant ache or intermittent pain? Or is it morning or at night time? Is there any specific time? Then we ask about radiating factors. Does it radiate to the ear, the upper lower jaw, the temple area? And then we ask about aggravating factors, such as what makes it worse? Is it hot, cold, biting, biting on a specific angle or on release? Is it laying down or bending forward that causes the pain to get worse? Is the pain spontaneous? Is the pain nocturnal? It's also important to ask about duration. How long does pain last? Is it lasting for seconds, minutes, hours? It indicates the type of pulpitis, reversible versus irreversible pulpitis. Inhibiting factors such as hot, cold, and biting, or sometimes medication can help, such as antibiotics or analgesics. So, have they taken anything? Has it been helping? And other factors such as systemic signs. Has there been any swelling, any difficulties swallowing, breathing, any fever, for example? Also important to ask about intensity of the pain. Rate the pain out of 10. Has it been getting better or getting worse? The nature of the pain or the characteristics of the pain, such as is it a short, sharp pain? Is it a dull, throbbing ache? Is it getting better, same, or worse? And any other associated symptoms, such as clenching, grinding, has there been any bad breath or taste associated with pus? Now that we've taken a comprehensive history of the pain, we go into a clinical limited examination. Starting off with extraoral clinical examination, we look at any signs of swelling, difficulty swallowing, limited mouth opening, lymphadenopathy, fever, and we also palpate the muscles. Then intraorally, we look at soft tissue, looking for any signs of sinus tract swelling. For hard tissue, we look at visual signs of any caries, restorations, any signs of wear, abrasion or attrition lesions, any fractures of the tooth, or any discoloration of the tooth. Investigations that we can do include probing, palpation, percussion, pulp status testing, and mobility testing. And we also need to consider other factors such as occlusion and fremitus. So now let's go into detail about intraoral soft tissue examination. And starting off with, we look at sinus tract. A sinus tract is a communication between a pathologic space and an anatomic body cavity, or between a pathologic space and the skin. A sinus tract opening may appear a distance away from the source of infection, and that's why it's important to trace the sinus tract with a Gauda-Perker point when taking a radiograph. An abscess is a localized collection of pus contained within a cavity and is fluctuant. An abscess contains dead tissues in the center surrounded by a fibrous capsule which limits the infection from spreading. Now, lancing and draining the swelling with a scalpel can help to speed up the healing process in combination with appropriate dental treatment. Or there could be a diffuse and spreading cellulitis, which is a diffuse soft tissue infection with swelling and poorly defined borders. And this is accompanied by systemic signs such as pain, fever, and tiredness. For cellulitis, we have to treat infection within the tooth with root canal treatment or extraction, but we may also have to supplement this with antibiotics. If it's a localized lesion that we can drain, we don't always have to give antibiotics. Periodontal probing is another test that we can do. The type of vertical probing defects indicates if the origin is periodontal, endodontic, structural, anatomical, or combined periodontal and endodontic lesion. Palpation is another test or investigation that we can do. We can palpate around the tooth, the root area, the periapical area for any soft tissue swelling, and we compare the result with other areas of the mouth, such as the contralateral teeth. Percussion testing, again, we always have to compare suspect tooth with adjacent and contralateral teeth. And not all teeth with an endodontic disease will have a response to percussion testing. Tenderness means that there is an acute inflammation in the periodontal ligament, but the cause of this acute inflammation can be pulpal from within the tooth, it can be mechanical, such as trauma, or it can be periodontal in origin. Now, mobility is another factor we need to consider. The mobility reflects the extent of acute inflammation within the periodontal ligament. An apical periodontitis pushing the tooth out of the socket can present with mobility of the tooth, and this mobility may decrease after root canal treatment is completed. But again, we need to compare the mobility with adjacent and contralateral teeth, because there are many causes of mobility besides a pulpal infection extending into the periodontal ligament. And this can include periodontal disease with loss of bone support. Occlusion is another factor we need to consider. Hyperocclusion and parafunction is another possible cause of percussion sensitivity, so tenderness to percussion. We look at prominent muscles of mastication, which may result in overloading of teeth, and we can also check occlusion of any recently completed restorations in the area. Fremitus is basically hyperocclusion causing mobility and is another factor we need to consider. Special tests that we can do include radiographs such as bite-wing radiographs, periapical radiographs. Sometimes a CBCT is indicated, and an OPG, if it can be requested and interpreted in a medical setting, it can be helpful as well. Pulp status testing usually involves the use of a cold thermal stimulus or an electric pulp testing machine. A frac finder is an instrument that we use to help us detect any fractures of the tooth. Pulp status testing in the form of a cold thermal stimulus will help us to replicate a patient's symptoms, for example, pain to cold water. This helps us to identify and diagnose the offending tooth, and a positive response indicates vascularized pulp. The results may describe the quality of the pulp. For example, in a normal pulp, we may have no pain or very moderate transient pain to cold thermal stimulus. In the case of reversible pulpitis, we'll have a sharp pain that subsides quickly once the stimulus has been removed. An irreversible pulpitis case will have lingering pain after the stimulus has been removed. In the case of pulpal necrosis, there will be no response. And in the case of dentine hypersensitivity, there will be heightened response to cold. So as we can see, no response may mean a number of things. It may mean normal pulp, it may mean pulpal necrosis, it may mean pulpal neuropraxia in the case of trauma. It can also mean pulpal calcification. So we have to take all the test results into consideration when diagnosing and managing odontogenic pain. So thank you for listening in, and hopefully this provides some useful background information when taking a history and examining a toothache patient. In the next discussion, we'll put the information we've gathered so far into practice and see how we can approach the case of a typical toothache patient in a medical setting.